కంప్యూటర్లోనే రాలేదు, మళ్ళీ నెక్స్ట్ టైం వస్తే కొంచెం డిఫెక్ట్ ఉంది చూసుకోండి. ఇన్నొచ్చారు స్టార్టింగా. So today's topic is a common topic, is a hypertension. There are various types of hypertension that we come across in patients, which affects more than 50 million people in the US. And so you have primary hypertension and secondary hypertension. The primary can be a chronic high blood pressure without a source or associated with any other disease. Most common form of hypertension you have secondary hypertension is renovascular hypertension. So various causes which will produce the secondary hypertension. The genetics, some people are prone to hypertension simply based of their genetic makeup, family history, and your risk for high blood pressure, hypertension, which increases in family history. If family members are suffering with hypertension, mother, father, etc., grandparents. So the environmental factors which will affect the hypertension: the inactivity, stress, obesity, alcohol, high sodium diet, tobacco use. As age advances, the hypertension will increase, and menopausal medications, if anybody is using the estrogens and progesterones, can produce hypertension. The further complications of high blood pressure will produce thickening of the heart muscle, cardiomegaly, and increased workload of the heart will increase because the left ventricle has to pump against the peripheral vascular resistance, and may lead to other conditions such as heart attack and stroke and renal failure and loss of vision due to hypertensive retinopathy and hemorrhages in the retina. The African Americans have a higher risk of high blood pressure and hypertension, and 40% of all Americans in the US will develop hypertension in comparison to 27% in white populations. And this is due to the African Americans which usually respond differently to blood pressure medications than American whites. African Americans have a higher sensitivity to salt, and so half teaspoon of salt can raise your blood pressure 5 millimeters of mercury. The signs and symptoms which are diagnosed and through the repeat blood pressure readings. The primary hypertension does not have symptoms other than high blood pressure. Secondary hypertension, the most likely caused by renal disorders and symptoms, and you will see decreased urine formation and increased sodium and water retention leads to hypertension in renovascular disease. The renovascular disease, usually the main cause of renovascular heart disease is atherosclerosis. If they have atherosclerosis, the proximal 1/3 of the renovascular hypertension, proximal 1/3 will have renal artery stenosis, which will be irregular in shape and which will also have the connection with aorta. Invariably, they will be associated with atherosclerosis of the aorta. The etiology of renovascular hypertension is mostly the patient is a young individual or middle-aged women will produce fibromuscular dysplasia, intimal dysplasia, or peripheral dysplasia can also result in a renal artery stenosis. Atherosclerosis, the commonest in elderly individuals. Fibromuscular dysplasia is commonest in young and adolescent, so which is very common, which can produce renal artery stenosis, or due to trauma or due to mass compressing upon a cyst or mass compressing upon the renal vessels can also produce stenosis, or patient who has taken some radiation therapy can also produce renal artery stenosis. And the renal artery stenosis, once there is a renal artery stenosis, and usually the renal artery stenosis will produce decreased renal blood flow. As a result, a decreased GFR will be reduced and renal perfusion will be decreased. In sequence, there will be decreased urine output to the individual, and it may also elevate the renal and creatinine level in the blood. So usually the creatinine levels, mild decrease in creatinine levels will have a marked damage to the glomeruli. And this is how the renal pathology usually, and there will be vasoconstriction of the efferent vessels in the renal glomerulus. As a result, the decreased renal renal blood flow, decreased GFR, and increased serum creatinine. As a result, decreased glomerular filtration and efferent arterial vasospasm will further produce aldosterone levels, which increases the water and sodium retention in renovascular hypertension. On physical examination in a patient with renovascular hypertension, you find that patient will have a renal bruit, which may be palpable per abdomen, or it can be heard by the stethoscope, which is also one of the reasons which can produce renal artery stenosis. Then how do you diagnose renal artery stenosis? The renal diagnosis of renal artery stenosis: physically the patient may have a renal bruit, which may give you a clue that patient might be having with renal artery stenosis. The proximal 1/3 of the renal artery stenosis suggests that the patient is having renal artery stenosis could be due to atherosclerosis, and if it is in the middle and the periphery or in a smaller vessels, that goes more in favor of fibromuscular dysplasia, or Takayasu disease, which can also produce aortoarteritis, Takayasu. disease which can produce renal artery stenosis. Okay, so how do you diagnose? So the investigations that you make to make a diagnosis of renal artery stenosis is ultrasonography of the abdomen, which can tell you that the affected side, the kidney size will be less, and hypoplastic kidney on the affected side, and on the opposite side, usually um, the kidney will be normal. And then, if you do a color Doppler test of the abdomen and the renal vessels, can demonstrate the size of the renal vessel will be narrower than the opposite side. And the venous drainage, and the arterial system, the blood vessel size can be delineated in a color Doppler test, which is of great help. And MRA is of great value in making a diagnosis, which has got a lot of value because it is a non-invasive technique by which you can make the diagnosis of renal artery stenosis. The next test is the gold standard, and you get your chest X-ray done for the evidence of hypertrophy of the left ventricle because of hypertension. Long-standing hypertension can produce hypertrophy of the left ventricle in a renal artery stenosis. That's one. And of course, routine investigations like blood urea, blood sugar, and serum creatinine will be usually raised in this patient because of decreased renal perfusion and decreased renal glomerular filtration. This is how you make it an gold standard test for renal artery stenosis is renal angiography. You do a renal angiography in these patients. By puncturing the femoral artery and pass a guide wire into that, and through which a renal this catheter is passed up to the level of the renal artery and little above the level of the renal artery origin in the abdomen, and then go little above the level of renal artery, and then inject radioactive substance like renographine is a radio opaque substance which can be injected, which will pass into the renal arteries, which will delineate the renal vessel anatomy. So most of the renal kidneys will have a double renal artery supply. 25% of them do have two renal arteries which will supply the kidneys, and most of them may have only single vessel, which is a thick vessel originating from the abdominal aorta, and some of them may have even the collaterals originating from the vertebral arteries. These renal vessels are very well delineated in renal artery stenosis. If it is atherosclerosis, usually stenosis will be proximal, 1/3 of the renal vessel, and that will be seen. And if it is due to fibromuscular dysplasia, the renal artery will be dilated and multiple aneurysms will be seen in the middle or in the distal portion of the uh, arteries. And bizarre picture may be seen in aortoarteritis like Tauchiasis disease or peripheral fibromuscular dysplasia is seen in small children and adolescents. That can be, and this angiography, renal angiography, is a gold standard to make a diagnosis of renal artery disease. And second thing is the patient. So, renal artery angiography is a gold standard test to make a diagnosis of renal artery stenosis. And once you make the diagnosis, you have to plan the treatment. The treatment of renal artery stenosis, of course, the hypertension, if it is more than 140 by 90 millimeters of mercury, that has to be reduced properly with drugs other than ACE inhibitors. So that is one. And second thing is any drug can be used to reduce the blood pressure by titration method using one drug and adding second or third depending upon the number of drugs that we add to the patient. After usage of the first maximal dose, second drug can be added. And physical exercises may be of great help in reducing hypertension. And second thing is the drugs may not be of great help in bringing down renal vascular hypertension. The best thing is the best treatment that can be offered to the renovascular hypertension is you get an angiography done at the same time you can do renal angioplasty. You can pass the balloon through the stenotic segment and then inflate the balloon to stretch the narrowed segment of that particular vessel, which is of great help and which increases the blood flow to the kidney and decreases hypoxia, thereby it reduces the renin-angiotensin mechanism. The hypoxic kidney can produce renin 1 and renin-angiotensin. Angiotensin will be secreted by hypoxic tissue from juxtaglomerular apparatus. From there, angiotensin 2 is angiotensin 1 is converted to angiotensin 2, which is a potent vasoconstrictor, results in hypertension. And in turn, as the angiotensin increases in quantity, aldosterone also comes to play the role in maintaining the intravascular volume by absorbing more water and sodium and increasing the blood pressure. This is the mechanism which can be operating in a renovascular hypertension. So, which can be reverted or reduced by giving a renin angioplasty, the renal artery angioplasty. And once the angioplasty may not be sufficient to treat the patient of hypertension. Next is The stenting has to be done. After angioplasty, if you put a stent, a drug-eluting stent which can elute the vasodilator substance, which can maintain the patency of renal artery. The renal artery stent can be placed in the renal artery. That can be done in a renal artery stenosis. And second thing is, if the damage is so much and it cannot be managed with even renal artery stenosis, and renal artery bypass can be attempted with a venous graft. You can take a venous graft from saphenous vein and then do renal artery bypass from the. You can take the anastomotic bit from aorta and then bypass the narrowed segment and anastomose to the vessel where there is no narrowing. That also can be done in these patients. And another thing is when the patient develops refractory hypertension with renal artery stenosis and the hypertension cannot be controlled by using many drugs, even 2 to 3 drugs or 4 drugs of maximum dosage. The hypertension cannot be controlled. In such a situation, the hypoxic kidney can be knocked out. It can be damaged by injecting some lead into the, or you can plan a nephrectomy. Hypoxic kidney can be removed so that the renin dependent hypertension can be very well controlled with drugs. That is how you manage a patient of renal hypertension. By and large, the hypertension, and this is the way we should manage the patient with hypertension. And second thing is how to manage a patient of hypertension by and large. The general principles, the step one is lifestyle modifications. And the diet and exercise, of course, and the low salt diet means less than 5 grams of diet in 24 hours, salt in 24 hours. And limit alcohol and tobacco use and reduce stress factors, which are very, very important. These are the diet and exercise, and then you and limit the alcohol and tobacco use, and binge alcoholism should be avoided in those patients and reduce stress factors. And second thing is step two. And if lifestyle changes are not enough and drug therapy has to be introduced, that is the step two. And by and large, these steps will hold good for any type of hypertension. And then you have if previous steps and do not work, and drug dose or type will be of changed or another drug is added. If one drug used in the maximal dosage, if it does not bring down the blood pressure, you can add one more drug to the patient. And then step four is more medications are added until blood pressure is controlled. That means use in step two one drug, step three 2 drugs, and step four is 3 or 4 drugs can be controlled. Then the prevention. The prevention, you see, the lifestyle changes, having regular checkups and with your physician, and education, and being aware of your blood pressure and where it should be used. And it should be checked very frequently, or you can, if your patient is educated, you can order an automatic blood pressure, which can show the pulse, blood pressure regularly, morning and evening. Next is understanding your personal risk factors. And risk factors like diabetes, control the diabetes, hypertension, control the hypertension, keep it in normal limits. Smoking should be abundant, and then alcohol should be made moderate, or better stop it. And engaging in these are all the personal risks, are and any drug addictions like cocaine, heroin, all that should be reduced. And the cocaine is a very potent vasculotide which can produce or even renal vasculitis, and can produce renovascular hypertension. And engaging in the community health awareness and activity, so, and where you can detect the hypertension in camps, and then you can do justice to the patients, and where you can make a diagnosis of essential hypertension or secondary hypertension of any kind can be made out in the. So living with high blood pressure requires a lot of lifestyle changes, diet, exercise, taking prescribed medications without fail, and recognize it as an ongoing process which requires regular checkups, and see that the blood pressure does not increase. And then recognizing can be the complications with pregnancy and hypertension, and high blood pressure with kidney damage, which causes kidney damage and nephrosclerosis, and patient may go into renal insufficiency, and low with and damage to kidneys, leading to hypertension and renal failure. And so, suppose if you do not treat the patient of hypertension and pregnancy, and the child may have low birth weight babies, and then preeclampsia. If you detect the preeclampsia in early stage, and you can prevent the abortions and the children's mortality and morbidity in patients who are so. So this is how you should treat the patient of hypertension. Sorry. Hmm.